text in or say yes over there. Okay. So, hello guys, I welcome you all. Good evening, everyone. I am Ishika Jain and I am Scientific Project Lead of Watery Dandy Neurosurgical Students Club India. And today we are here for our fourth resource presentation program, which is being conducted fortnightly. That is every 15th day on second and fourth Saturdays of the month. So, this is the program based on the research presentation methodologies, and two presenters are selected based on first come first basis, who will be presenting one after the other. The presentation will be there for 10 minutes, which will be followed by the discussion of 5 minutes. So all the audience, I will request you to be very attentive and you can ask in the questions anything pertaining to the paper to the presenters. Also, the other moderators and the other presenter can ask the question. So it is going to be an interactive session. I guess we are good to go with this. Rachit is one who will be presenting first on epilepsy. So you can start. You can share your screen.
Thank you very much. Just a moment.
Yeah.
Uh, does the screen looks good?
Yeah, it's perfect. So we guess we are starting your time limit from now
Okay,
on.
so hello everyone. Okay, so hello everyone. Welcome to the presentation program. Myself, Ruchit J. I'm an intern from Government Medical College, Meerut. Today, I will be presenting a paper on depression in adults with epilepsy, attending epilepsy clinic in tertiary care hospital. So, epilepsy is defined as a chronic disorder which is characterized by recurrent and unprovoked seizures. Seizures are defined as increased brain activity. Depression is defined as a mood disorder where the patient suffers from lowering of mood, reduction of energy, and decrease in activity. Many studies have shown that depressive disorders are the most common type of psychiatric comorbidity in patients with epilepsy. Patients with uncontrolled seizures are more likely to suffer from depression. Despite their relatively high prevalence, depressive disorders remain unrecognized and untreated in large population of patients. Depression lowers the quality of life significantly, yet it is an eminently treatable condition. Depression can directly increase seizure frequency through mechanism of sleep deprivation. Failure to recognize depression or inadequate treatment can lead to suicide. Doctors in epilepsy clinics often fail to diagnose depression in their patients, and even when they do, may remain inadequately treated. Furthermore, psychiatric comorbidity adds to the burden of living with epilepsy. But ironically, even though India has the largest number of epilepsy patients, along with the high prevalence of depression, there is scarcity of Indian studies in this area. Thus, it prompted us to take up this study in order to find the relationship between depression and epilepsy patients. So aim of this study was to investigate relationship between depression and epilepsy in patients. Objectives were to study the depression attending epilepsy clinic on the basis of the PH-9 scale, to study the prevalence and severity of depression on the basis of PH-9 scale, and to study the relationship between various socio-demographic variables, depression and epilepsy. So methods, it was a cross-sectional study done over the period of 2 months. It was done at epilepsy clinic in a tertiary care hospital, and the sample size for this research project was 50 patients. Inclusion criteria was the patient was diagnosed with epilepsy, the patient should be above 18 years of age, and patient should be willing to give informed consent from the study, and patient should be able to comprehend the questionnaire. Exclusion were patient with already diagnosed psychiatric disorder and patient with other medical comorbidities. Ethics committee clearance was taken before starting the study, and the patients who were willing to participate were included in the study, and written consent form taken from the participant. Principal investigator took the information related to socio-demographic profile of the subjects, and the translated version in the vernacular language was used. PH-9 scale is a multiple choice self-report inventory. It is used as screening and diagnostic tool for mental health disorders. It is a 9-question version and has been developed and validated. It is a multi-purpose instrument used for screening, diagnosing, monitoring, and measuring the severity of depression. So this is how like PHQ-9 was looks like. Scoring was done on the basis of the scores, which is uh, given as not at all, that is 0. 1 is given for several days. 2 is given more than half the days, and nearly every day was given the score 3. Basically, we asked the question, we asked the patient about the mood over the period of 15 days. After having all the 9 questionnaires, we add the score and we classify depression in like mild depression, that is 5 to 9, moderate depression 10 to 50, moderately severe, and severe depression. And SPSS software was used for statistical analysis. Uh, so, uh, in males, the minimum age of the patient was 20 years and maximum age was 71 years. In female, the minimum age of the patient was 18 years and maximum was 70 years. As you can see, 64% of the patients were male and remaining were females. We classified marital status into 4 stages: single, married, widowed, and separated. So, as you can see, the majority, half of the patients were married. Family history, almost 92% of the patients didn't have any family history of epilepsy. Most of the patients had the onset of epilepsy after the 18 years of age. 84% of the patients were were having good compliance with the medicine. That means they were taking their medicines regularly. Uh, Around 70% of the patients who were participated in the study were seizure free. That means they didn't have any seizure within 3 months of the treatment. Last seizure episode. We divided last seizure episode in 3 parts. That is less than a month, more than 1 month, and less than a year, and more than 1 year. So, on the basis of the PHQ-9 scale, as we divided the depression in the 4 clinical parts, that is mild, moderate, moderately severe, and severe. As you can see, 10 patients were mild, 6 were moderate, 7 were moderately severe, and 4 were severe. So we find out various relationship between various social demographic details and severity of depression. The social demographic details were included: sex, literacy, employment status, socio-economical status, marital status, family history, onset of epilepsy, compliance, current status, and last seizure episode. So, as p-value was calculated using SPSS software, and association between the various social demographic details and depression was found out. So, as you can see, the factors which are associated with depression were included: compliance of the drugs, that means whether they are taking their drugs regularly or not; current status of epilepsy, whether they had seizure episode recently or remotely; and the last seizure episodes. Discussion. The aim of the study was to assess the prevalence and associated factors of depression with epilepsy. So, as you can see, 54% of the prevalence of depression in this study. Out of this patient, when we divide the scales of depression basis on PHQ-9 scale, 20% show signs of mild depression, 12% show signs of moderate, 14% show signs of moderately severe depression, and 8% show signs of severe depression. Our highlighted study highlighted also that around half of the patients were in the age group of between 30 to 50 years. And as you can see, the most of the association between social demographic details and depression were: first, poor compliance to the anti-epileptic drugs; second, the patients who were having uncontrolled seizures; and third, patient who had the last seizure within month of life had severely higher prevalence of depression. Strength of this study. This study adds important data in the area of depression and epilepsy in an Indian setting where there is scarcity of evidence. This also points out that epilepsy related factors were found very significantly more in the depressed population, and this can be used as a screening procedure for epilepsy patients to rule out depression. The limitations of this study: as it was a cross-sectional study, it does not confirm the definitive cause and effect relationship, and there is overlapping symptoms between depression and epilepsy. Also, the adverse effect of anti-epileptic drugs also overlap with symptoms of depression.
We have 2 minutes left.
Conclusion, depression is an illness with significant morbidity and mortality, and the association with epilepsy is very strong. Various factors contribute to depression, which include compliance of the drug, last seizure episode, and current status of epilepsy. Unfortunately, it is very much underdiagnosed and therefore untreated. A psychiatrist should evaluate the patient with epilepsy for depression, and appropriate treatment would be started. These are my references for the study. Thank you so much.
Thank you so much, Rajit. I would request the audience if they have any questions, they can write it in the chat box and also they can just unmute themselves and ask it. Uh, do we have any questions? Christina, am I audible?
Yeah, Ashika, you're audible.
Yeah.
Okay, so I have a question, Ruchit. As you have told PHQ-9 scale,
Yeah.
can you please elaborate on that? What it is?
Uh,
Okay. So basically, if you want to, diagnose a patient with depression, there are many of the scales used. So there is Beck's depression scale, there is Hamilton depression scale, and there is this PHQ-9 scale. So about PHQ-9 scale, it came out in the year 1994, and at the time of that, DSMB-5, that is Diagnostic and Statistical Manual 4. It was a book, or it was a checklist which includes the signs of depression and which can be used all over the world to diagnose a patient with epilepsy. So PHQ-9 scale just came 4 years after of DSMB-4. So the 9 questions which are present in the PHQ-9 scale contains all the symptoms which are present in the depressed patient. For example, low mood, anorexia, insomnia, overall mood reactivity, social activities, etc. So these are the sets of 9 questions which are already present in the PHQ-9 scale, and which can be it is actually a layman term questionnaire. That means any person can read it easily and comprehend the questionnaire, and it can give the answer easily. You don't need an actual psychiatrist to explain the question to the patients and all. And it mostly contained all the points that are covered in DSMB 5 or DSMB 4, so that the the efficiency of this questionnaire is better as compared to other questionnaires such as Beck's and Hamilton, which were released in the year 1963 and 1964. And as you fill out the questionnaire of the 9 questions, a total score comes which ranges from 0 to 30. And on the ranges of scales, we classified the severity of depression in mild, moderate, moderately severe, and severe.
Okay, I think that's really a good explanation of the scale. Also, I have one thing to ask. Like you mentioned, key in the inclusion criteria that the patient should understand, should have an understanding of the questionnaire. So, also later on, you mentioned ki that it has been like replicated in different vernacular languages, depending on ki what is the understanding of the patient. So,
Yeah.
do you find anything like there is non-overlapping of these two things? Like, did you find any exclusion of patients because of this criteria? Like, I didn't find it to be one of the significant thing. Just asking that as well.
Okay, so what happened is uh, when I conducted the study for myself, my hospital is in very rural area. So what I did was I converted my PH9 scale from English to Marathi,
Okay.
and then we generally ask the simple question to the patient who arrived, whether you can read or not.
Okay. Cool.
So if they were able to read the questionnaire, we included them in our study, and those who weren't, we didn't include it. We excluded them from the study.
Okay, okay, cool. That's great. So I think we have no other questions from the audience side. Uh, Someone asked what's the difference between PHQ 8 and PHQ 9. Can you answer this?
Okay,
Vignesh asked this question.
okay,
Yeah.
so Vignesh, actually, what the concept is actually PHQ9 scale is divided into various forms. So there is PHQ4, there is PHQ8, and PHQ9. The PHQ scales were upgraded every few years, and PHQ9 scale was used because it was just came after DSMV 4, because DSMV 5 came in the year 2013, and DSMV 4 at that time was the latest. So PHQ9 scale just came after this DSMV 4. So the 8 and 9 basically are the numbers of question that are present in the questionnaire. That's it.
Mm, I
And
guess you
actually,
are.
PHQ9 scales not only is used for depression, they are also used for various disorders like panic disorder, anxiety disorders. PHQ9 scale is most commonly used for depression.
Cool. I guess Vignesh, you are convinced with the answer. Yeah. Okay. So I think we can move ahead with our second research paper. So Mayank would be presenting it on the topic neuroma. Mayank, you can share your screen.
Yeah, sure. Just a minute.
Yes, it is visible.
Okay, just a second. Start new. Okay, no, sorry. Question and answer. So, is the first slide visible? Sorry.
Yes, yes, it
Is,
is visible.
so, hi everyone. You can start my timing.
Yes.
Okay, so hi everyone. My name is Mayank Karyani. I'm a second year medical student at North Bengal Medical College. So, my topic of my article is intramuscular peripheral nerve sheath tumors, which includes schwannoma and ancient schwannoma and neurofibroma. And the authors are written below. Next slide. So, to give a brief introduction, peripheral nerve sheath tumors are formed in major peripheral nerves, as written in the name, and are commonly located in the intermuscular space. Now, when a nerve is involved, there is a patient presents with a Tinel sign. This Tinel sign also helps us to suspect a PNST through the clinical grounds. Now, if we want to suspect a PNST with the help of MRI findings, there are some findings or signs we can use to diagnose it. So the purpose of the study was to analyze the prevalence of the classic MRI findings of PNSTs for intramuscular PNST of schwannoma, ancient schwannoma, and neurofibroma. So the materials and methods were the eligibility criteria. A total of 93 patients were initially selected, whose eligibility criteria was they should have a pathologically proven intramuscular mass, and they should have an MRI which includes contrast enhancement. So after that, almost 32 patients were excluded because they had lipomas, and from the remaining rest of the patients, there were two groups formed. One was the case group, and the other is the control group. The case group consisted of the PNSTs, and the control group consisted of the non-PNSTs. So now the materials and methods, the statistical analysis was done with the help of T-squared test, Mann-Whitney used test to compare the findings between the groups, and a software was used for the same, which was SPSS for Windows. So MNN's imaging techniques. This was a retrospective study. Now, the relevance of the retrospective study here was there was no consent required, and so the ethics committee waived the consent requirement. And so the MRI was performed with 1.5 T and 3 T scanners, and with the help of fast spin echo T1 weighted and gadolinium enhancement of T1 weighted images. And gadolinium is a contrast agent which helps us to for the clarity of image. Now, second point, two radiologists with different years of experiences were blinded to each patient's clinical history and imaging experts, and they gave their review, and the review were consensual, so there were no conflict of interest. So M&M's imaging analysis. So reviewers evaluated the split fat sign on T1 weighted images and the vascular sign, target sign, entering and exiting nerve sign, and thin hypertense ring on T2 weighted images. And we'll talk about all the signs now. The split fat sign, if you can see in this image, if you see the crescent arrow, if you see the arrow, you follow a crescent shaped fatty end. That is the fat sign, the split fat sign. And there are different kinds of fat signs. It can be triangular or combined shapes. Now, the main important thing here is this split fat sign was the most common finding for benign PNSTs. So it helped us to differentiate from the malignant. And the other part here in the A image, you can also see the triangular fatty ring. We'll talk about the edematous in the next slide. So there were vascular sign too. As you can see in this image, if you follow the arrow, there is hyper intense ring. Hyper intense means brighter, so brighter ring, and had spots like hypo intense spots, dark spots. So this is known as the fascicular sign. And what is target sign? If you see here, so at the above image, which is T2 weighted, so here you can see that it is hyper intense rim and hypo intense core. This is known as the target sign. And we have the thin hypertense rim, which you can see here. Just a second. Here. So at the image B, you can see the hyperintense rim with the arrowheads, small. This is the hyperintense rim sign. And with the entering and exiting nerve sign, this is quite difficult to comprehend. So usually they find the continuity of the nerve resembling a tail coming of the tumor as tail sign. So as you can see here, at the above image A, you can see a tail coming out, right? So from the arrow, so that is the tail sign. And another sign is the other sign changes are these are denervation changes of the affected muscle, which includes edema and atrophy of the muscle. So edema, as you can visualize here, this is edema, the asterisk shaped area, and asterisk marked area, and we know what is atrophy, which is the decreased muscle volume and fat deposition. So after coming this off, now the results. As you can see here, at first the age column, if you see the mean age of the ancient squamoma was 57.6, which is greater than both of those things. This also shows the property of the ancient squamoma, which is slowly growing degenerative aging. So beside this finding, there were most of the locations were morely prevalent to the thigh and the lower leg region, and these are not basically conclusive because this was a small study. This chart about the MRI findings of intramuscular PNSTs, you can see the split fat sign is 100%. It's shown in every PNSTs. So this is a very important sign. Also, if you see that, and all the other signs are being present in squamoma. As you can see, there are 24 cases, but in ancient and neurofibroma, there are three cases. So it was hard to get more signs. So you can also, about the whole conclusion of it is the presence of classical signs was 100% for squamoma, but 0 and ancient squamoma and neurofibroma 1. So so it helped us to diagnose when a schwannoma used to occur. So about the case results 3, as you can see in this classical findings, which differentiate between an PNST and a non-PNST, you can see that PNSTs have a presence of classical signs greater than equal to 2. That means you can diagnose it from the MRI. They have a classical MRI findings which helps you to separate it from the other non-PNSTs. Basically, that's it. So here, as we can see in the previous cases, that the findings of MRI of the ancient squamoma and neurofibroma were very uncertain. So we needed to find a particular trait which could help us diagnose this. So if you see in this case, the heterogeneously hyperintense SI that had they were present in both the cases. Now discussion. If you see the split fat sign which was initially shown, was present in all the PNSCs. However, it was also present in 71% of the non-PNSCs. So it is less specific. So, and second point, use of MRI findings is uncertain in case of intramuscular ancient schwannoma and neurofibroma. In contrast, but we can help to diagnose it through some different kinds of changes which are not the classic signs. For example, muscle denervation changes in ancient schwannoma and intramuscular tumor without peritumoral edema and with typical Christian fat sign in upper and lower lobes could be considered differentiated features of intramuscular neurofibroma. So the limitations was this was a retrospective nature. The study was of retrospective nature. So there was this study could have selection bias, and the study population was relatively small, which I told earlier. And the conclusion is more than two classical findings were observed in intracellular schwannoma. So we got the classical signs for intracellular schwannoma, sorry, and also the intramuscular. And there were no classical signs for ancient schwannoma and neurofibroma, but we got certain characteristics as written here. For example, Christian split fat sign in upper and lower poles in neurofibroma, and so that's it. And these are the references. And so, thank you.
That's great. I would request the audience to ask the questions now, whether in the chat box or they can also unmute themselves and ask directly. I think this was really an interesting topic, so you must have lots of questions. Like if you would have been attentive enough.
Did I rush it or what?
Yeah.
Okay.
Anyone from the moderator? I do have one question, ma'am. Can you explain like what is the tender sign? Like I could spot it in your very initial slide. Can you explain me the tender sign? I could spot on the initial slide, like.
Which one? Okay.
Tender sign.
Oh, tunnel sign. Oh, see. So when we talk about the major peripheral nerves, for example, median nerve.
Yeah.
So if a person has a certain disruption in that nerve, so if we press that nerve at a certain location, so there will be an irritation in that nerve along its distributory branches. So we can help distinguish whether that nerve has a problem or not through the help of its irritation in its distribution branches. So that is known as the tunnel signs.
Okay, cool. Yeah, I get it.
Basically, it's a way to detect irritated nerves. Yeah.
Do anyone else have other questions?
Hello. Yeah, so I have a question. Hello, am I audible?
Yeah.
Yeah, Mayan, can you please explain the difference in crescent and triangular fat split sign?
Okay, awesome. So I'll pull up the
अच्छा यार एक बात बताना कि जैसे कि मान लो कि मैंने स्ट्रीमलाइन कर दी, ठीक है?
So if you see here, this is the crescent sign. As you can see, this crescent sign is kind of thin, right? So this is due to the displaced fat. Now, if a muscle is displacing fat, so this produces a crescent shaped fatty ring. So another important point I must suggest for a T2, this is if you see this is a T1 weighted images. So here you see the crescent sign. While in the triangular sign, this is due to the fat split sign, that is the displaced fat plus muscle atrophy. So you can see this has a mass, a triangular mass, but that one is a line-like figure which is just due to a displaced fat. So this is displaced fat plus muscle atrophy, and this is displaced fat. Simple.
हाँ वो आप लोग भी पिछली बार हो गया था, हाँ डिस्कस कर रहे हैं.
How to feel like one has a line like figure and another has a mass.
Yeah.
I guess we have no more questions and we have to wind up this session today. It's been really great to see you.
मैं मतलब बैडमिंटन खेलने चला गया था, फिर मैंने 2 घंटे बाद आके चेक किया, फिर भी गोल घूम जा रहा है.
So
उन्होंने बंद ही कर
we'll
दी
be making a poster or diagram which will be related to these
कहीं पर सुनो कि
resources
ऐसे
and
गोल्ड
so
स्टूडियोज
on.
पे 5-10 मिनट
And
प्ले
the
करके
most
देखता हूँ
highlighting
इसी लिंक पे
facts
बस
of
ला के
resource
देखूंगा क्या
be
पता
present. Along
अपलोड
with
हो गया
that,
हो
we'll tag the
बताओ
presenter as a boost
ठीक
to
है
them. So see you guys
चलो
next time
थैंक
in
यू
the next meet another resource program. I hope this would have encouraged you and add something to your knowledge. So I think we're good to go. Yeah. All can leave. Bye bye.